If you are a runner or a triathlete experiencing pain around or behind your knee, chances are you may have patellofemoral pain, also known as runner's knee. Hi, I'm Dr. Kate Baldwin. I'm a physiotherapist, sports scientist and researcher, and today I'm going to explain to you the most common running injury, which is patellofemoral pain or runner's knee. Now, you might be thinking, how do I know if I have this? You will often report to healthcare professionals something like, I have pain here, underneath or around my kneecap, and it hurts when I do anything anytime I bend my knee, or nothing else seems wrong except for these bending knee activities. Also, don't be fooled, even though it's called runner's knee, this can happen in cyclists. So if you were a cyclist listening to this as well, or a triathlete, this is obviously applicable to you. So how do you know if you have runner's knee and not something else? Normally this is diagnosed from your history plus a couple of little specific tests. In fact, if you were to go for an MRI, generally in athletes with runner's knee, it can come back pristine with nothing wrong, which is good news, of course. It's not downplaying your pain, but that is good news. So generally things that you will report that reproduce your symptoms is going up and down steps. That is a big one. Sitting for a long time. This used to be known as a movie theatre sign. So sitting for a couple of hours, and running and cycling, of course. Simple tests that we can do to reproduce this pain involve doing a squat or a step up or a step down. But here's the nuance, especially for endurance athletes and long distance runners. You might get runner's knee just with a long run. So let's say, for example, you're training up for a marathon, you're getting close to race day, and you go and do a 30-kilometer run. And perhaps your pain doesn't come on until kilometer 20. Now, if I were to get you in the clinic and do a step up and a step down or a squat, it may not reproduce your pain because you don't get symptoms necessarily just doing that when you're in a fresh state. So your tip here is, if you were going to see a healthcare professional to manage this, which you should, make sure that you go into that appointment feeling fatigued. So yes, I'm giving you permission to go for a 20K or even longer run before your appointment, because that will help us exacerbate your symptoms so we can know what is going on, and that will help us diagnose it. So that's a really handy little tip there. Now, what else could this be if it's not runner's knee? Let's make sure that we're on the right track here. If you're getting pain on the outside of your knee, this may be more likely to be ITB syndrome. If you're getting pain just above your kneecap, this could more likely be quadriceps tendonitis. Pain below your kneecap could more likely be something known as jumper's knee, so that's more patellar tendinopathy, and pain on the inside of your knee could more likely be MCL or meniscus. Now, I know I said you don't need a scan, but if you do have any form of these symptoms, make sure you get the right diagnosis, and also you might want to scan if you want to rule out anything like a bone stress injury in that area. They will show up on a scan. So why do runners get runner's knee? There are lots of potential contributing factors, including quadriceps weakness. So that is weakness through the muscles of your anterior thigh that do that knee extension or straightening out through the knee. It could also be weakness and poor strength through the hip abductors and external rotators. So here you're really thinking of your glute med and your glute min. When they are weak, you will see movement patterns like more excessive hip adduction. So that's your knee falling in towards the midline. You may also have excessive foot pronation, so that is where the arches of your feet are more flat than, I suppose, what's normal. A lack of hip extension, so that is your hip extending back behind you. That has been shown in athletes with runner's knee to be up to 11 degrees shorter. And same with a lack of ankle dorsiflexion, so restriction into that, which is where you're trying to point your toes up or doing a knee to wall movement. On the contrary, you may also be hypermobile, which can increase loads through that knee joint as well. Other factors can be psychological, so if you've got quite high stress levels or have a big life event going on, that can contribute. And of course, if you get these symptoms on your bike fit may be contributing if your saddle is too low or too far forward. However, I worked with multiple runners who don't necessarily have any of those, and they still present to me with runner's knee. And that is more often than not because they've just done too much, too quickly, with not enough rest. In fact, this is the most common thing that I do see, is it's athletes who may have ramped up the intensity of their runs or done steps or hills in their runs and suddenly introduced that, or really, like I said, ramped up that intensity and then compounded this with not enough rest, and the body just hasn't had time to adapt, and they've ended up with runner's knee. And to really confuse you, I'm going to say also it's generally a combination Often athletes do too much too quickly, and they might have some underlying quadriceps weakness or hip strength weakness there as well, and those combined have resulted in that runner's knee. So let me summarize this for you to make sure you're on the right track and really explain runner's knee. It is pain around or behind the kneecap, often triggered by running, stairs, squats, or prolonged sitting. It's generally not caused from one single issue. It's generally an overuse injury, plus or minus those movement patterns and deficits that I touched on. There's generally no structural damage with runner's knee. It's more of an irritation, and there's nothing broken, out of place, or necessarily wrong structurally, which again is good news. It is generally caused by a mismatch between the load and your body's capacity. And the good news here is that it is treatable and completely reversible, which is exactly what I'm going to go over in the next video for you. So I'll see you in that where I'm going through short-term management, things that can really help immediately. See you then.